Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. Apologies for the delay, had to step out for some work. But here we are to kickstart this today's Fast 5 discussion where we have some interesting questions. I hope all of you are making the best of the Fast 5 free test that we are having on Medsynapse app by Dr. Nikita. Where you have these clinical based questions, actually these are one-liner facts but which are put in the form of a clinical scenario to help you basically understand how the questions can be framed. A quick note whether I'm audible and visible, let me also check that. The PDF has been attached to the test already. If you go to the Medsynapse app in the test, you'll be able to see the PDF there. Just give me a minute, I'm trying to see the live chat, just a minute. Sonal, I do not get to know from the username that whether मेरा subscriber है या नहीं है. So there's nothing like that. If you think like that, I think that's a misconception. I think even the subscribers would say that मैम आप हमारा भी query answer नहीं करते हो. चलो, let's start. So we have a 65-year-old woman here who dies 6 months after onset of severe headaches. A brain autopsy is shown. So reading the last line here, what is the most likely cell of origin of this neoplasm? What do you think is this neoplasm shown here, and where is the neoplasm? So this is the brain shown from the undersurface, and this is where you are seeing a tumor here, right, in the interhemispheric fissure, though frontal lobes ke beech mein is where you are seeing the tumor here. So this tumor is basically extraaxial, right? This is an extraaxial tumor which is meningioma, okay, which is meningioma, right? So yeah, the origin for meningioma is going to be meningeal origin. It is going to be meningeal origin. So look at the classical history given here. It's a woman. Meningioma is more common in females as compared to males because it is progesterone receptor positive, right? And it is extraaxial tumor, well-defined tumor that you see here. This is not a glioma. Glioma is an intraaxial tumor in the brain parenchyma. Meningioma on the other hand is intraaxial or extraaxial. Meningioma coming from the meninges is going to be an extraaxial tumor. What sign do you see? Radiology, CT, MRI. Remember meningioma, which are the meninges? Dura is the meninges. It is the dural tail sign that we see. Another important question, tell me that meningioma is generally benign or malignant? More so, it's generally a benign tumor, like many times a female would have it and not even know it until the imaging is done because of headache or something. So generally it is a benign tumor, right? And the next point to be remembered that it causes hyperostosis or it causes the bone erosion. So if this is a meningioma overlying the bone here, does it cause the bone erosion or does it cause the hyperostosis? So the concept here, a tumor which is slow growing, which is there for a long time, causes the sclerosis of the bone, the hyperostosis of the bone. A tumor like metastasis, which is fast growing, causes the erosion of the bone. So remember, it causes hyperostosis, previously asked point. And very good, Karthik, yes, it also shows calcification. So do we see samoma bodies here? Yes, we see samoma bodies here. In which thyroid tumor we see samoma? Papillary, ovarian serous, then you have meningioma, mesothelioma, right? These tumors show samoma body. So the answer here is meningeal. Astrocyte is going to be the cell of origin for glioma. Endothelial is for the vessel. So a tumor like hemangioblastoma. Okay, a tumor like hemangioblastoma, which is seen in which syndrome? It is seen in von Hippel-Lindau, H for H. Remember, hemangioblastoma is seen in von Hippel-Lindau syndrome. Is this clear with everyone, guys? So, I've got this image for you to show this tumor, which is extraaxial, vividly enhancing tumor, and showing this dural tail sign. Okay, it is showing this dural tail sign that we are seeing here. So, a quick snippet in your fast 5, a fast snippet, that is first aid simplified teaching. So, common tumor, it's typically benign. Okay, females are affected more, and it is extraaxial, not intraaxial. It has a dural tail sign, right? The treatment is resection or radiosurgery. Radiosurgery basically means we can do a gamma knife treatment. Okay, we can do a gamma knife treatment for meningioma. Okay, we can do radiosurgery, that is gamma knife. From where is it originating? The arachnoid cell origin. Spindle cells which are concentrically arranged in a whorl pattern, that is, and also the psammoma bodies, laminated calcifications, that is psammoma bodies, are seen here. Clear with everyone? Done with this? Let's move on to the next question now. What do you think is the answer to this one? Whenever you have lengthy questions like this in the exam, and this is where the trend is moving to, all you have to do is first read the last line. Yes, ninjas, absolutely. So, which of the following is the strongest predisposing risk factor for this patient's condition? So, I know that it's asking me about some risk factor for a condition in a patient, and what condition is being mentioned here. So, we look at the second last line. Examination shows a thick, firm, white pleural tumor that ensheathes the right lung. When I see a pleural tumor ensheathing the lung, basically what tumor is it suggestive of? It is pleura. What is pleura lined by? Mesothelium. So, the tumor here is a mesothelioma, because remember, when I say pleura, the lining of the pleura is the mesothelium. So, this is a mesothelioma which encases the lung without causing the mediastinal shift called as fibrothorax, associated with asbestosis, and asbestosis is associated with working in a shipyard. Okay, that is associated with working in a shipyard, and that's why the answer here is this. So, you can also see that it's mentioned that chest x-ray shows a right pleural effusion and associated ipsilateral scallop-shaped pleural density. Basically, the most common radiological finding in asbestosis are pleural plaques. Okay, it is the pleural plaques which is associated here. So, shipyard is important here. What is the tumor marker for mesothelioma? Remember, the tumor marker is calretinin. Okay, it is calretinin positive. It is calretinin positive. Yes, asbestos bodies, ferruginous bodies, dumbbell shaped is what you see in asbestosis. That is the ferruginous bodies, dumbbell shaped bodies. Okay. Radiation therapy, smoking cigarettes, this is a risk for the lung cancer, bronchogenic carcinoma. Raising pigeons is an important history for what condition in the lung? Raising pigeons is an important history for hypersensitivity pneumonitis. Hypersensitivity pneumonitis. So, I remember in my residency that whenever we used to see features of hypersensitivity on the HRCT chest, we used to specifically ask for contact with pigeon. Ask pass me if there are pigeons. So, hypersensitivity pneumonitis, very, very important. Okay. Clear with everyone? This is about asbestosis, and remember that asbestosis affects the base, the lower lobe of the lung. Asbest affects the base of the lung. Okay, it affects the base of the lung. Okay? Clear with everyone? Blastomycosis, nahi. It is hypersensitivity pneumonitis. Going to the next question here, guys. Everybody give me a quick thumbs up there if this is clear, so that we can move on to the next question. Great. Tell me, what do you think is the answer to this one now? Again a lengthy question. Let's have a look at this one. Impairment of which of the following is the most likely cause of these findings? We are looking at the options. We know it is something related to acetylcholine on postsynaptic membrane. Then you have presynaptic. So something related to your neuromuscular junction, myasthenia gravis, Lambert-Eaton syndrome. So what do you think will be the answer here? नहीं, धूम मचाले A से incorrect answer से is not how you धूम मचाले, right? Correct answer, I don't know, you have some weird names here. Very good. The answer here is definitely going to be the presynaptic release of acetylcholine. Okay, it is because what are you seeing here? What is the most important history that is given here? There is pronounced weakness of the hip girdle muscles, shoulder girdle muscles, right? And on the chest X-ray there is a hilar lung mass, okay? And remember that it is improving with repetitive testing. Very, very important keyword here. All these are important here. So when you will solve these questions in the fast 5, and then you'll be able to remember a particular condition better, because this is like a case that you are seeing. All of you would agree that if you see a case in your wards, in your clinics, in the OPDs, right, you never forget that case. So similarly, if you solve clinical questions on the topics that are asked in the exam, you remember them in the form of those questions. That was what was put in the question and the answer was this particular option. So in this question, why am I highlighting these points here? Weakness of the hip girdle muscles is basically in your Lambert-Eaton syndrome. You have proximal muscle weakness, which is more. The hip girdle is the proximal muscle. Okay, it improves with repetitive testing, important here, and the hilar lung mass. Hilar lung mass is basically telling you small cell lung cancer. Small cell lung cancer associated with Lambert-Eaton syndrome. With myasthenia, what would have been the answer, the option correct for myasthenia? Binding of acetylcholine on the postsynaptic membrane. So what happens in Lambert-Eaton and in myasthenia is, so in the Lambert-Eaton, the problem is for the presynaptic. Remember, L comes before, M comes after that. So presynaptic is Lambert-Eaton and myasthenia is postsynaptic. This is presynaptic voltage gated calcium channels affected, and that is why depolarization not happening, the neurotransmitter is not released. So it's a problem with the release of acetylcholine. In myasthenia gravis, it is a postsynaptic acetylcholine binding which is a problem. In myasthenia, it is basically the fatigue, the weakness which increases with exercise, with action, more in the evening. All that is given in myasthenia gravis. So that is going to be the history for myasthenia gravis. This is the Lambert-Eaton syndrome. Okay, this is Lambert-Eaton syndrome. So let's have this fast snippet again, comparing the neuromuscular junction disease, myasthenia gravis and Lambert-Eaton syndrome. Okay, so myasthenia gravis is more common clinically that we see here, the antibodies against postsynaptic acetylcholine receptor. Here it is presynaptic calcium channel which decreases the acetylcholine release. Here clinically, what do we have here? Ptosis is given very commonly, right? There is bulbar muscle involvement, there is difficulty chewing. Here it is proximal muscle weakness and there can be autonomic symptoms also. Autonomic symptoms like dry mouth, constipation, impotence, all these can be seen with Lambert-Eaton syndrome, right? And so remember that here the reflexes are spared. Here you will see hyporeflexia also. The reflexes are depressed in Lambert-Eaton, okay? And you have this worsens with muscle use, it improves with muscle use. With muscle use, the acetylcholine accumulates and the symptoms improve, okay? Myasthenia is associated with thymoma, anterior mediastinal mass, while this is small cell lung cancer. In your myasthenia gravis, if you use a acetylcholine esterase inhibitor, which increases the acetylcholine levels, it reverses the symptoms, and here it has minimal effect. So what do we use for treatment? Is pyridostigmine. Pyridostigmine gets the patient rid of myasthenia. Okay. So this is what is shown here. The antibody to calcium channel will be seen in Lambert-Eaton syndrome. The antibody to postsynaptic acetylcholine receptor will be seen in myasthenia gravis. Is this clear with everyone? Right? Small cell lung cancer has a lot of paraneoplastic syndromes. Lambert-Eaton is one of that as a paraneoplastic. Absolutely right. It is one of the paraneoplastic associated with small cell lung cancer. Okay? Is this clear with everyone? Very good, Chandani. So this is about your third question. Myasthenia is very, very important. What drug do we use in the diagnosis of myasthenia and what drug do we use in the treatment? Treatment we have seen is pyridostigmine. For diagnosis of myasthenia gravis, it is, for diagnosis of myasthenia gravis, the drug that we use is edrophonium. It's a short-acting acetylcholine esterase inhibitor drug. Remember, DR, doctor makes the diagnosis. Edrophonium, DR, doctor makes the diagnosis. Okay? Tensilon test is what it is called. Tensilon test. Going to the next question here. A question from psychiatry. What do you think is the answer to this one now? What is the diagnosis in this case? Is it schizoaffective? Yes, this is a brief psychotic disorder. So we have discussed in our short 5.0. When do you call it generally a brief or an acute disorder? When the duration is less than 1 month. Here you have a duration given of 2 weeks. Duration of what is given here? He has heard 2 male voices for the past 2 weeks. That means there is auditory hallucinations. So when the hallucinations are present, which of these option is ruled out? Delusional disorder is ruled out. Delusional disorder has only delusion, no hallucinations. Has been asked in one of the recent FMGE exam also. Delusional disorder is only delusion, no hallucination. At least 1 month is what is the duration that we have here. Bipolar disorder will have depression and mania symptoms there. Schizoaffective, affective means the mood also is affected here. Okay? So this is a disorganized behavior that is mentioned here. The patient crouched in the closet even when there is no intruder. Right, so that is disorganized behavior, auditory hallucinations for 2 weeks. When there is hallucinations, this is a psychotic disorder, not a neurotic disorder. Okay, it's a psychotic disorder. So a quick snippet again from your first aid to quickly revise the schizophrenia spectrum disorders. So there we have schizophrenia, schizoaffective, delusional and schizotypal personality disorder. Again, do you remember from a short what was the keyword for schizotypal personality disorder? Very good, Kartika. That is the magical thinking. Typing the magic book, short 5.0. So typing, there is magical thinking which is there. Okay. This is a cluster A personality disorder. In schizophrenia, what is the minimum duration that we need in schizophrenia? Remember, schizo is 6 so. That means it is how much duration? 6 months. Schizophrenia. The minimum duration is 6 months. Okay. The requires, it is the symptom onset is more than 6 months and it requires at least 1 month of active symptoms over the past 6 months. What do you have there? Delusions, hallucinations often auditory like in this patient, disorganized speech, disorganized or catatonic behavior and the negative symptoms is what we have here. Okay, clear with everyone? The negative symptoms are more difficult to treat. The positive symptoms are easy to be treated comparatively. Heavy cannabis use in adolescents has increased risk here. Okay. Going to the schizoaffective, Schizoaffective, there will be, to differentiate from a mood disorder with psychotic features, patients must have more than 2 weeks of psychotic symptoms without a manic or depressive episode in the mood disorder with psychotic features, right? Next, what you have is, this is schizoaffective, schizophrenia and mood. Delusion is delusion lasting at least 1 month but without a mood disorder or the psychotic symptoms. So basically the learning point here is, for schizophrenia, schizophrenia 6 months, for brief psychotic it is less than 1 month. Bipolar will have features of mania, delusional disorder is only delusion and no hallucinations for minimum of 1 month, okay, for minimum of 1 month. Is this clear with everyone? Schizo, schizo, brief is less than 1 month, delusion is more than 1 month. Delusion will not have any hallucinations, okay. Going to the next one, the last question here, what do you think will be the answer to this one? Which of the following biochemical pathways is most likely defective in this patient? So what are we seeing defective in this patient? What is the answer to this one? Very good. It is heme synthesis, because what is the diagnosis that is there in this patient? This is porphyria. The most common porphyria in adults, that is porphyria cutanea tarda. So the skin is sensitive to sunlight. Exposure to sunlight gives vesicles and blisters on the skin, compounds that are subject to excitation by visible light. Okay, so this is porphyria cutanea tarda, the classical image of those blisters, vesicles on the dorsum of the hand, right? So this is heme synthesis. Okay, this is heme synthesis, porphyria. Do you have an acute intermittent porphyria? Is there photosensitivity like this in acute intermittent porphyria? Is there only photosensitivity? Is there no photosensitivity? Is it neurovisceral? What kind of porphyria is acute intermittent porphyria? Very, very important point to be remembered. Remember, in acute intermittent porphyria is only neurovisceral, very, very important. There is no photosensitivity in acute intermittent porphyria, which you get in cutanea tarda. Okay, cutanea is cutaneous only. There are no neurovisceral there. We have discussed the topic of porphyria, is available in the Medsynapse app in the main videos, biochemistry, do watch there. Okay, so very, very important to remember the enzymes. Right, which is dominant, which is recessive, what are the manifestations. This is how the image is given on the dorsum of the hand, porphyria cutanea tarda. There is this lesions here. The enzyme deficient here is uroporphyrinogen decarboxylase. Okay, decarboxylase, C for cutanea tarda. And there will be tea colored urine here. Okay, there will be tea colored urine because of uroporphyrin. Blistering cutaneous photosensitivity, most common porphyria, which can be precipitated by alcohol, also associated with hepatitis C. So sun avoidance, antimalarials like hydroxychloroquine can be given. Look at this heme synthesis pathway, your snippet from the first aid. Glycine is important for heme synthesis. The rate limiting enzyme is ALA synthase. Vitamin B6 is required for that. So when this is deficient, there is going to be sideroblastic anemia, X-linked. Then you have ALA dehydratase, which is inhibited by lead poisoning, and also ferrochelatase inhibited by lead poisoning. Then you have acute intermittent porphyria, which is porphobilinogen deaminase, which is affected, or which is uroporphyrinogen 1 synthase. Okay, 1 synthase. Then you have porphyria cutanea tarda, where you have uroporphyrinogen decarboxylase, which is affected here. Right, is this clear with everyone? So you can see that here it is starting in the mitochondria and then it is going to the cytoplasm. So heme synthesis is something which is hug both the mitochondria and cytoplasm is required. Starts in the mitochondria, goes in the cytoplasm, comes back to the mitochondria. Ferrochelatase, ALA synthase are here in the mitochondria. Okay, so protoporphyrin is the last one. First is the uroporphyrinogen, then coproporphyrinogen, and then protoporphyrin, UCP, uro, copro and proto. We have discussed the other various types of porphyria, variegate, congenital erythropoietic, all of that we have discussed in our, yes, very good. So you remember the mnemonic, Kartika, very good. You remember mnemonics very well. ER is AR, okay, erythro wale autosomal recessive hote hain. Absolutely right. Remember the association of cutaneous tarda with hepatitis C. Okay, remember the association with hepatitis C. Right, so those were basically your fast 5 for today. Quickly revising in one-liners, what did we see today? What was the first question that we saw today, guys? Let us see a quick recall of whatever the 5 questions. The first one was meningioma. Meningioma arises from the meninges. Can you tell me the tumor marker for meningioma? Immunohistochemistry? Is it desmin? Is it vimentin? Is it cytokeratin? What is the tumor marker for meningioma? Oswald, absolutely right. For AIP, the mnemonic is PIH. The enzyme deficient in AIP, it is PIH. बताओ मुझे ट्यूमर मार्कर क्या है मेनिंजियोमा वाला? इट इज विमेंटिन. रिमेंबर MEME, meninges, mesenchymal, endometrial is vimentin. Okay. What was the next question that we saw, guys? We have the 5 questions for today. What was the next one that we saw? एक था meningioma. What was the next question? Yes, quickly. So there was one question on asbestosis, the question on mesothelioma. Okay, the question on mesothelioma, asbestosis, shipyard working is the important risk factor there in asbestosis. What was the next one? The last one we saw, we remember because we have seen just now, is porphyria cutaneous tarda, increased sunlight sensitivity, right, excited by light, that is what we saw. And what were the middle 2 questions? Yes, Lambert-Eaton syndrome and your myasthenia gravis. So we had seen a question on Lambert-Eaton where on repetition it improves. Okay, it improves on repetition. There is proximal muscle weakness. There can be autonomic features. The deep tendon reflexes are depressed. It is presynaptic calcium channel. And what was one more question, the 4th question there? Yes, what was the 4th one? Brief psychotic disorder. Very good. One was the brief psychotic disorder. Duration less than 1 month, similar to schizophrenia, but the duration is less than 1 month. For schizophrenia, the duration should be more than 6 months. That is when we call it schizophrenia then. Brief psychotic will have hallucinations like schizophrenia, but it will be less than 1 month. Okay, it will be less than 1 month. So this is where I have given you the summary, right, so that it's easy for you to revise, and you'll get the annotated PDF also along with the test series is where I'll replace the blank PDF with the annotated PDF for you guys to revise, so that once you have given the test, later on once we finish the sessions, you can revise the PDFs from that test series section in the Medsynapse app by Dr. Nikita. And when are we meeting next? We are meeting next in the next 1 hour again at 8 PM, but this is going to be in app for the subscribers on the Medsynapse app, where we are going to discuss pathology PYQs, AIIMS PYQs. Okay, pathology PYQs of AIIMS. Today it's not a test, it's a live KBMD, Kaun Banega MD, where you answer in the live session and you get the leaderboard in the class itself. So it's a KBMD pathology AIIMS PYQs at 8 PM for all the subscribers. Do join in there at 8 PM for pathology PYQs. Tomorrow we will have pediatrics AIIMS PYQs in app. Okay, so tomorrow we will have pediatrics AIIMS PYQs. Yes. Okay, thank you so much everyone for joining in, and I hope you found this session useful. If yes, do like this video and share it with your friends as well, your juniors, who do you think would benefit out of these sessions. And every day you have the Fast 5 test on the Medsynapse app, which is free. So to enhance your MCQ skills, make sure you are giving the test every day. Okay. Thank you so much. Goodbye. Take care. Keep studying, keep revising, keep Medsynapsing, and keep winning. Thank you.